Hello, everybody. My name is Mike Lagerquist. I'm here with Vine Faith in Action, and today we're hearing from Jeff Buchanan, who's got some great information to share. Jeff is a professor up at Minnesota State University Mankato, and he has been a pretty regular expert of ours to speak. So I am going to turn my microphone off and give all of our attention to Jeff Buchanan. Thanks, Jeff.
Wonderful. Thanks, Mike, and thanks, Carol, and thanks to everybody at Vine for inviting me to be here. I always enjoy coming to speak with the Vine group. I do a lot of speaking to 18, 19, and 20-year-olds, and they're wonderful people. But sometimes the information that I have to present on older adulthood and aging is not incredibly relevant to them. So it's always nice to have a group of people where this information, I think, means a little bit more, and I usually get a lot more questions from this crowd. So it's always a pleasure for me to get in front of a group from Vine. There's a number of familiar faces there, but there's a few of you that are not familiar to me. So I'm just going to tell you a little bit about myself, and then eventually I'll share the screen here with you and share my presentation with you. But I've been here at MSU for about 17 years. I'm in the psychology department, and my background is in clinical psychology. So I've spent most of my career in developing an expertise in what's called geropsychology, or working with older adults with mental health issues. So my general interests are in mental health and aging. And then within that, I developed a lot of experience and expertise in working with people with Alzheimer's disease related conditions and their caregivers, whether they be family caregivers or professional caregivers that work in assisted living facilities and nursing homes. So I've really had the opportunity to work in dementia care in a lot of different capacities. So I've worked in, for example, neurology clinics doing the neuropsychological testing with individuals who might be diagnosed with dementia. I've spent a lot of time doing caregiver support groups. I've done one-on-one and family counseling with families who are kind of living with somebody with Alzheimer's disease. So I've seen this from a lot of different angles. And then I always like to share too, whenever I speak in front of a group like this, is that I've also had Alzheimer's disease affect me personally. After I got into this during graduate school, my grandmother developed Alzheimer's disease and kind of slowly and gradually progressed to the point where she needed to be in a nursing home. So I've seen this personally. I've seen my mom, my folks, my uncle deal with this. I've dealt with it myself personally to some extent, but then professionally, I've worked in dementia care in a lot of different capacities. So that's kind of what I'm bringing to the table. And now Carol came to me with the idea of doing this presentation because I think it's one of the more difficult questions, is that Alzheimer's disease and related dementias have such a slow and gradual progression and onset. It's hard to know when something is happening, something of real concern is happening, or is it just something that's fairly normal? So making this distinction between just what is aging and getting older and what is something to be of concern, there's a big gray area there. And I should mention that although the science is progressing and diagnostic accuracy rates are quite high, there's still a lot of, I would say it's still somewhat of an inexact science in some ways, is that we hope in the near future there's going to be blood tests or a simple brain scan that's inexpensive, that there's going to be some simple biological tests that will tell us, yes, you have this disease. There are those capacities in research settings, but not so much in clinical settings. So my point there is that making this distinction between when is something concerning and when is it just getting older is still, there's a lot of gray area and there's a lot of inexact science in there. And so I'm going to talk through a little bit of that today in a number of different ways. So what I'll do is I'll share my screen with you here in just one second. If people have a question, it probably makes sense to just unmute yourself and feel free to interrupt me. I'm quite used to it. I've been a teacher for 17 years with young people. I get interrupted all the time. I have a 10-year-old at home. I get interrupted all the time. So it's really not, it's not a concern for me. But if you want to wait till the end, that's perfectly fine. If you want to type your question into the chat, you can certainly do that. And Carol, I think, is watching that. And I should also be able to see those at some point. So in one way or the other, we'll get your questions answered, whether you want to do it immediately or wait till the end. That's perfectly fine. So with that being said, I'm going to share my screen here with y'all. And just let me get set up here. All right, and you'll also need to keep in mind too that I will only be able to see a few of you. So if you try to get my attention in any way, there's a good chance that I won't see you. So again, you can unmute yourself or throw a question into that chat box there. And I should also mention that my email address is on this first slide. If you end up with questions afterwards, or you just have some questions in general about Alzheimer's disease and dementia, I'm happy to answer those as best as I can. So never hesitate to contact me directly by email, and I'll get back to you. That's for certain. So there's a number of things actually that I want to cover today. The main stuff being points number 2 and 3. So I'm going to give you a few statistics. I'm not going to bombard you with a lot of statistics and numbers, but I'm just going to kind of set the stage with a few numbers there. And then the meat and the potatoes of what I'm going to talk about are going to be some of these guidelines for distinguishing what is just normal stuff and when is it something of concern. And unfortunately, I'm not going to have a nice recipe or a simple checklist, but it's going to be a lot of guidelines and things to look for. So then we'll talk about what some of those specific early signs and symptoms are. I'm going to talk a little bit about the importance of early diagnosis, because sometimes that gets a little bit overlooked, because many people know that right now there's not really great treatments for Alzheimer's disease and related conditions. So I think sometimes there's the attitude, well, we can't do anything about it, so why put my loved one through the process of getting a diagnosis? And actually, that's how my mom and her brother handled my situation with my grandmother. They just took care of her, but never got a formal diagnosis. But it was painfully clear what was actually going on. And then I'm going to talk a little bit about how to get the most you can from your interactions with your physician, because there can be a lot of concerns and frustration sometimes that families have in interacting with medical professionals. And we'll talk a little bit about that, but how to get the most of your time. But I'm going to start with some questions here. And this would be a time where I would be happy to have people jump in with any stories or anecdotes. But this is just to kind of get things started and give you a sense of what it is I'm going to be covering. But I'm curious, and you don't have to answer this out loud, but how many of you are concerned about your memory or other intellectual abilities? Some of you may be here just because you're curious. Some of you may be here because you're worried about someone that you care about or love. But what I know from doing some kind of version of this talk in front of people that are over 65 is that when I ask this question and I ask for a show of hands, I get a number of hands that go up. It's a very legitimate concern. And again, I'm going to show you a few numbers about that. But I am curious, and feel free to unmute yourself and throw out some examples about, I call them cognitive failures. Some people call them Alzheimer's moments, some people call them senior moments, but those things that happen on a day-to-day basis that they kind of sometimes concern us. So a real common example is I walk into a room, and this happens to me quite frequently. I walk into a room and I knew I went in there for a reason, and I just can't exactly remember why. But I'm curious if there's things that you all might experience that are similar to that, where it's just things feel like with your memory and thinking aren't working quite as well as you would like them to. So again, feel free to unmute yourself if you would like to. I'll wait here for just a few seconds and see if anybody's got some examples of what those things might be.
For me, it seems to me like I can't find the word more often, and that really concerns me. It's a word that I should know, and all of a sudden the word is just not there. It's kind of comparable to people's names, which also fail me at times, but I can describe the word, it's just not there. And that bothers me sometimes.
Gotcha. And that's a really common experience, and that's something that I will touch on. That happens to me too. I do enough speaking where I'm trying to, I know it's almost, I can see the word almost, I can feel it. I can sometimes just like almost can taste the word. It's right there and I just can't find it. And I can talk around to the word. And I think that's what you're kind of driving at is that,
Yeah.
but the exact specific word that you want. And I'm a guy who likes words. I want to use that kind of ideal perfect word when I want to use it. And not being able to find it is very, very frustrating indeed.
Mhm.
So yeah, that's a perfect example. Other kinds of examples of those types of things that anybody wants to throw out there.
This is Mary, and I was trying to, a 4-letter word. I was looking for urge in my brain. Luckily, I do a lot of texting. I bet it's been a long time since I used it. I actually had to sit there and as soon as I remembered, oh, it starts with a U, it helped. Or I might start running the Culligan water right over the countertop and then forget to turn it off. Or a couple, today was interesting because Don said, I thought we had the doctor. We were listening to Governor Walz, and I'm like, he doesn't have a doctor appointment. I said, oh, you mean Dr. Buchanan at Vine? So he has worse memory than I do. But those are some examples from around here. And he has even, I hate to admit it, but I might put something on to cook and then I'm like, I'm going to run out and get the newspaper. And then a neighbor stops me. And you know what Mary McGaw does? She forgets she's cooking. So I say to myself, you're not allowed to leave. And I don't think that would have been such a problem when I was younger. So
Gotcha. And so you've found a way to compensate for that, but it's concerning when that kind of thing happens. I know again in my own life that I think it was just happening today where I'm going to do one thing and then I get distracted by something else and then I start to do that and nothing actually gets finished, but I kind of start 10 or 12 different things. So that's not terribly unusual, but it certainly is concerning when it's something like cooking a meal or leaving the water running or something of that sort. So yeah, those are, again, are fairly common kinds of examples. Other things that people want to throw out.
Let's see, I'm sorry, I don't know if you've talked to Virginia. I see a response here, an unusual outburst of emotion. Is that a
Okay. Gotcha. So just again, something that's out of character clearly for you as my guess. And any others? I don't want to cut anybody off.
Yeah, I have one. The password to get into my computer. I've known it for a long time. Every once in a while, I just can't remember it. Have to look it up.
Mm-hmm. Yep. And what's interesting about all of these things is that when they happen once in a while, and this is going to be one of the guidelines we talk about, once in a while is generally not a huge concern. It's when they become a pattern. But I can also tell you that I've given you a few examples from my own life, and so I can relate to some of these things. But what I also know is that when they happen to me, and I'm 48 years old, they're things that they catch my attention, but I don't think a lot of them. They don't cause me a lot of distress. I have a feeling 20, 25 years from now, those exact same things can happen, and they'll probably take on a very, very different meaning for me. And I'm guessing that might be true for some of you out there, is that these things have happened to you in the past, but all of a sudden now there's a bit of a heightened concern about them, because what does this mean? This could mean something else.
And Jeff,
are there?
yeah, we also got D has said watching a show and the next day you can't remember what it was about.
Yes. Yep. So that's another pretty good example of the exact kind of things that I'm talking about. Anything else in the chat, Mike?
Nope, that's what we've got right now.
Okay, very good. Well, those are really, I think, on point examples. And so what, for at least some people, when those kind of things happen, one of the things comes to mind is that, gosh, am I losing my mind? Am I losing my marbles? Do I have Alzheimer's disease? Is that something that's coming? And that will typically be even more common if you know somebody who has one of those diseases, or if it's affected you and touched your family in some way. If you've had a family history, all of a sudden those things start to mean a lot more, and people develop a lot of concern about those types of things. One other thing that I do know is that when people have those concerns, a lot of times people don't want to act on it. They don't want to move in terms of getting it maybe checked out. And that's something that we're going to address a little bit here. So again, these things really mean a lot of, they mean something much more when somebody is at an older age compared to somebody middle age or younger. So these are just a few other examples, and you all touched on some of them, but you can just take a look and see if any of those sound familiar to you. I know one of those in the middle that when I've used a word and then I all of a sudden have this kind of feeling like, gosh, did I use the right word there? Or I can't remember if I actually used that word, if I used a different word. And then I'm in my own head thinking about what I might have done. So I know that these are things that some of them I can most certainly relate to as well. But these are the kind of things that are going to get our attention for sure. And then of course the question becomes, what does it mean? Does it mean anything in particular? Is it just getting older? As I said, we're going to get into that in just a minute. But not surprising probably to any of you is that you're certainly not alone in these concerns, is that fear of memory loss, dementia is incredibly common in individuals over the age of 65. Becoming dependent in terms of healthcare needs is the #1 concern, but memory concerns is right there at #2. So this idea of subjective cognitive decline, and I talk with a lot of older individuals who experience this, is that they feel like they're not as sharp as they used to be. They feel like there's some sort of cognitive decline, and it's usually memory, but there's other times language as well, like some of you mentioned, just not being able to find the right word or being able to articulate yourself in the way that you typically have. That a lot of people will describe those kinds of those concerns. But it doesn't affect their day-to-day life. They can still do the things they need to do. It isn't anything that's dangerous. It hasn't affected them. And if they've mentioned it to a doctor, they generally find no objective evidence of concern. So that's what subjective cognitive decline is that people they feel like there's some decline there, but it doesn't show up on objective testing, and it doesn't affect their day-to-day life, but it is concerning. And one of the other difficulties is that if it's concerning and it causes anxiety for people, I definitely know that anxiety also interferes with our thinking and our memory as well. So when we get more stressed about it, it can actually have this cyclical effect where it can then interfere with our thinking processes. So it can be a real vicious cycle sometimes. So again, when we know people who experience memory decline, these things mean all the more to us. And I'm sure many of you are familiar with the numbers in terms of Alzheimer's disease. And I'm focusing on Alzheimer's disease only because it's easily the most common form of dementia. And it's easily the most, I think, well understood and well-known form of dementia. So people's concerns are very, very real. And I completely understand it and I get it. These numbers are concerning and the projected numbers are even more concerning. So that is really just to kind of validate that many times if you express these things to people that you know, they may just say, oh, it's not a big deal. And that's very good advice. People are trying to be as helpful as they can be, but it sometimes can invalidate the real concern that people do have. So none of this is meant to alarm anybody, but it's really just to, again, kind of give some guidelines about when should I be concerned. So let's jump right into that piece of things. Again, this is really the meat and potatoes of what I want to get into. What are some of those early signs and symptoms? And I think one of the things I want to get across right away is that oftentimes we're looking for patterns of changes. So any one event is probably not something to get terribly concerned about. It's when there's an accumulation of events that begin to happen and certain kinds of events that we're more concerned about. And so where I'm going to start with is just really general guidelines. After this, I'm going to get into what are some of the more specific things that you might see and that you might notice to be concerned about. But again, because we don't have right now a simple, easy saliva swab or blood test or other kind of objective medical test to verify if somebody has dementia, and we do have those in research context, but just not in general clinical context. We rely a lot on people's self-report. We rely a lot on the reports of people that know the individual in order to make a diagnosis. And so these guidelines are really quite important in determining if something is concerning or not, because as I said, one-time things, rare events are not that big of a deal. But one of the first things is, are these changes? So somebody mentioned having an outburst of emotion. Well, having outbursts of emotion is a very human thing. It happens, but it's when it's unusual for you to have that kind of outburst. So for example, if it was an outburst of anger or frustration, and that's something very unusual for you, well, that's something I'm at least going to note. It doesn't mean that it is of concern, but that's going to be something different than, well, if you've always had kind of a short fuse, that's not really a change. So we're looking for changes. We're looking for frequency as well. So if you're having difficulties every once in a while finding those right words when you're talking to people, happens maybe once a week, once a month, I'm going to be much less concerned about that. But if it's happening most of the time when you have conversations with people, then that's going to get my attention a little bit more as a practitioner. And then clearly severity is part of this as well. Is it affecting day-to-day functioning? And I can't emphasize enough how key of a factor that is that any neurologist, any physician, if they're doing some kind of assessment of memory problems, one of the things they're really going to hone in on is this impacting your day-to-day life? Or if you're there on behalf of somebody else, is it impacting their day-to-day life? Are you having to do more for them, for example? That's really a key feature when this starts to bleed into something that might be more diagnosable, as opposed to just being an inconvenience or a nuisance or part of normal aging. Is this affecting multiple cognitive functions? So most people get concerned about their memory, but we're going to emphasize that cognition and intellectual abilities is more than just memory. There's a lot more to this. And so when you're noticing changes in multiple abilities, that's more concerning. And the other thing that's somewhat related to this, which can be really confusing, and some of you may be aware of this if you've known somebody with Alzheimer's disease or related condition, is that early on in the process, there can be really stark day-to-day fluctuations, where one day the individual just isn't able to make a cup of coffee or do the things they normally can do. They have a hard time communicating and their memory seems really poor. And then the next day they seem relatively themselves. And in the early stages of many of these diseases, that's the case. There's a lot of fluctuation. So that's what makes it even more difficult to catch these things early and diagnose them early. And that's why we really need those blood tests and those brain scans and those other objective medical tests, so that we can nail these things down earlier, because it's tough to do because those fluctuations happen. And when there's those fluctuations, we may kind of downplay some of the things that we saw the day before. Well, okay, maybe that was just a bad day. Maybe they didn't get enough sleep. Maybe we didn't forgot to take a medication. Maybe there's something different about what the person ate. So these are very normal kind of experiences. And then the other hard part about this is you may notice a number of different symptoms. And I remember giving this kind of advice to people, or telling people a lot this when I was more in clinical practice, is that we would tell people, you know what you're describing is concerning. It may be affecting their day-to-day life, but we're going to need to see you in 6 months again to see, okay, has there been a progression or not? And that's not exactly what people want to hear. That's not the answer that people want. They want a yes or a no kind of answer. And sometimes the answer you get is, well, we have to wait and see, because there might be just enough that's alarming, but we don't know. We have to see if it gets worse. And if it seems to be something that can't be modified in some way. So just as an example, I've known a lot of individuals where one of the ways they try to compensate is they'll carry around a calendar or a little notebook in their pocket, something to write stuff down so they don't forget things. Some people use a phone as well. And when those strategies begin to not be helpful, when they begin to forget to write those things down, to forget to refer to their notebook, that's telling me that something's more irreversible, and that's maybe something that's progressing. So we're looking for things that gradually change and get worse over time and don't seem to be benefiting from kind of compensatory or compensation strategies. So these are general guidelines. Now what I'm going to do is get into some of the more specific behaviors, but we always have to interpret those behaviors in terms of these guidelines. So that's why I wanted to talk about this first, because one thing you should know about me is that I teach abnormal psychology. I teach a lot about psychological disorders. And when you start going through symptoms of disorders, people start thinking, oh gosh, that sounds like me. That sounds like me. Oh my gosh, I think I have this. Kind of that medical student syndrome. We always have to interpret any one specific thing in the context of these guidelines. So if you hear something that sounds that it fits you perfect, and that sounds like me, it doesn't mean you should necessarily be alarmed. We have to go back to these guidelines on this slide to see, okay, is it really concerning, or is it just something that's fairly typical? So
Dr. Jeff,
yes, indeed.
and maybe you're going to get into this, but I was thinking of an example that I work with, and you know, she still holds intelligent conversations. She does her day-to-day, you know, eating and dressing and all those sort of things, but can't find her way to her room.
Mhm.
And you were talking about calendaring, and that's very important right now. She carries a slip of paper with her all the time. So I was wondering about the multiple abilities and when that takes place, but like I said, maybe you're getting into that now.
Yeah, that is one of the things we'll get into in just a little bit,
Okay.
is that one of the other things that's difficult related to your question there is that although I focus typically more on Alzheimer's disease, remember,
Mhm.
that's only one form of dementia. It's the most common, it's the most well known, but there's other
Okay.
forms of dementia. And so there are some forms of dementia where what you're describing are kind of more visual and spatial deficits. So being able to navigate through space and get to where they
Okay.
need to go. There are some forms of dementia where that's a much more prominent early sign. It is with Alzheimer's disease to some extent. So that is something of certainly of concern, because I'm guessing that that's a very familiar place to the individual.
Yeah.
And they technically should know where their
Mhm.
room is. So that is one of those things where if it happens pretty regularly, yes, it would be of concern, particularly if it's not modifiable by other kinds of interventions, and if there's few of these other things going on. So yes,
Okay.
that would be something that would catch my attention for sure.
Okay.
Yeah,
Thanks.
of course. Yeah, and hopefully I'll get into that even more here in just a little
Okay.
bit and answer your question even more thoroughly.
Okay.
But the changes in memory are, I think, some of the most obvious and most well known. Is that with many forms of dementia, they're going to impact that new learning, short-term kinds of memories. And this can be very challenging and confusing to some extent. I'm going to move myself over just a little bit because it looks like I got a ray of sunshine right on my face there. So an individual can reminisce about things that happened 50, 60 years ago and do so quite well, but they have a hard time with things that happened 20 minutes ago, 30 minutes ago, and recent things, remembering new stuff like when a doctor appointment is. And that can be very confusing, I think, to a care provider at first, because it doesn't seem to make sense how you can remember things that happened so long ago but not remember things that happened fairly recently. But that's one of the hallmark signs that I think many people are aware of. But forgetting important dates, so anniversaries, birthdays, again, physician's appointments that are coming up, things like that. Repetition of questions and statements. And this is one of those things that can be a little bit challenging, and it's challenging with a number of these symptoms, is that you always have to go back to that guideline. Is that a change or a difference? Because my grandmother, for example, would tell the same stories over and over and over again before she developed a lick of Alzheimer's disease. That was just something that she did. So when she was doing that more, it was easy just to attribute it to, well, that's just grandma. That's what grandma does. So the repetition has to be something kind of new, or if you've reminded somebody and then they repeat, that's much more of concern. The memory aids that we talked about before, the notebooks, the calendars, the phones, if there's a heavier reliance on that, that could be of concern. And then misplacing things. And then more importantly, we all misplace things. I do this every day. But if you lose the ability to kind of retrace your steps and go through a problem solving process, doesn't mean you'll necessarily find the thing, but if you can kind of retrace your steps and have a strategy for how you might find it, that's a good sign when you can still do that. You have an awareness that I've lost something and here's a strategy to find it. That's much less concerning than simply misplacing things. But if somebody begins to misplace things and then blaming other people for that, then we've got a bigger issue, or possibly a bigger problem. So they may accuse other people of stealing or taking things from them. That's a bigger problem. So then we have sometimes issues with orientation. In the early stages of many of these diseases, you may see, for example, well, you ask somebody the day of the week or the date, and they may not know. But an answer that I can almost read the minds of some of you out there saying, well, I don't really need to know what day of the week it is, especially in the day of the time of COVID here. I don't know what day it is half the time. I'm really glad that I made it here today, because Wednesday and Tuesday and Thursday feel real similar to me these days. Or I don't really need to know the date anymore because I'm retired. And so I hear that a lot, and that's a very legitimate argument. But at the same time, that's something that's going to get my attention at least a little bit. Most people in the earlier stages will know what season it is. They'll typically have a sense of what year it is, but the day of the week and date may be a little more confusing for some individuals. Getting lost in familiar places. So Sidel, I think that your example is a little bit similar to that, is not being able to find one's way back in a place that should be familiar. And that's the key part, in a place that should be familiar. And then not being able to come up with a problem solving strategy for finding that. So, many of us maybe go into a parking garage or a parking lot and forget, geez, where did I park my car? But you can develop a strategy for how to do that. You can think back, try to visualize where you might have parked, press the key fob to get the lights to go on, something. You can come up with a strategy to find it. But somebody who has a hard time doing that, then I'm going to be a bit more concerned about them. Being someplace and not being sure how one got there. That's a part of this confusion of time and place as well. Some individuals may confuse day and night in the earlier stages of these diseases. That's not as common, but certainly as things progress, that's more common. And then losing track of time and kind of misperceiving time. So some individuals may repeat questions over and over again because the 5 minutes that went by to them may feel like a much longer period of time. So just an awareness of time. Most of us have a general sense of what time it is. Most of us can probably give a sense of how long I've been speaking so far. You may not know exactly, but you have an idea. Somebody with one of these diseases may have a hard time making those estimates of time and the passage of time. And so there may be less awareness of that kind of time. When we look at more complex kinds of skills, you may notice, again, difficulties with numbers. So things like balancing a checkbook, making change may become much more difficult for some individuals. Multi-step kinds of activities, things that the person used to know how to do fairly well, like following a recipe or cooking a meal, making a cup of coffee, mowing the lawn. Those are things that many of us, particularly younger people, we take for granted. We just go out and do them. But when you break them up into a series of small steps, it's actually a very complex set of tasks that you have to string together a number of different mini tasks in order to make that thing happen, to cook that meal, for example. And that can become much more difficult with these diseases, partly because of some damage that's happening in the frontal lobe. And that's something you'll hear me refer to quite a bit, is that frontal lobe damage can really partially explain a lot of the things that you might be seeing here. And people may begin a task, but have a hard time sustaining. So sometimes individuals will say that they have a really short attention span, like they may start something and then move on to something else and not finish it, and start a lot of things but not finish them. So that difficulty sustaining attention and becoming maybe more distractible, that's fairly common in individuals that are developing one of these diseases. And then seeing poor judgment in terms of money, maybe spending money in ways that they typically didn't spend, giving money away in ways that they typically didn't give money away. So as you can see, I keep coming back to that criteria of, is this a difference? Is this a change in the person's functioning? If they've always made a big donation to their church every year, that's not a big deal. But if that's a difference or a change, or if they start sending money to telemarketers or spending money on things they don't typically spend money on, that's a big one. And I know in my own life, and I've been trying to alert my wife that if you notice these things someday, that means I might have Alzheimer's disease. I've been trying to give her a few pointers on this. And I tell her, if I start not caring about money, then you know something might be wrong, because that's one of my things. It doesn't mean that applies to everybody, but that's a big one for me. But that poor judgment may be seen with things like using power tools, managing medications, or driving, of course, is a big one as well. You can learn a lot about people by driving with them and seeing changes in driving. You'll see a lot of these things in a driving context if you have that opportunity. So Sidel, to your point, I think, where we get into this a little bit more specifically about visual and spatial relationships, being able to navigate through space. This is one of those things where, for me personally, this is a set of skills that I'm terrible at right now. And fortunately, my wife knows that. So if there's changes in me, or if there's problems with me 30 years from now in these spatial skills, it probably won't mean anything because I was never good at them in the first place. But if you have an architect, for example, who can't figure out how to hang a picture on a wall, then that's a pretty noticeable sign, because that should be easy for somebody like that. So judging distance, again, you can see this during driving. Discriminating colors, particularly things like green and blue, discriminating those kind of colors can be difficult. And frankly, that gets more challenging even in middle age and in normal aging as well. I play Uno with my son all the time, and by goodness, I can't tell the difference between the blue and the green cards if there's not enough lighting in there. But it is something that does happen with these diseases as well. Being able to put items together. So a puzzle, putting together, for example, a toy or a piece of furniture, a toy for a grandchild, that type of thing. If those things are becoming more difficult, and this is one thing that I've seen, at least personally in my own experience with older men who tend to be very hands-on, tend to be tinkerers, know how to take things apart, put things back together. This can be one of those early signs that something's not right, because if they're not able to take that motor apart and put it back together, or fix things that they typically have been able to do very easily, that can tell us something. Drawing complex figures. Now, this may not be something that you see in day-to-day life, but we see it in some of the testing that we do. We'll ask people to draw overlapping figures, and that can be challenging for people. Or even drawing the face of a clock can sometimes be challenging for people as well. Language things, which many of you have already given examples of, but these are new problems with language. So you may see this in social behavior, which we're going to talk about in just a little bit, but difficulties kind of initiating conversation and also maintaining conversation. Those can be early signs. So if we have somebody who's been typically in their life very chatty, very conversational, and we notice that they're not talking as much, or they're waiting for other people to react first, and that's not typical for them, that could mean that they're having difficulties kind of keeping up with conversation, of thinking about what to say, because conversation involves memory. To listen to somebody, comprehend what they're saying, think about what you're going to say next, then remember that, waiting for a pause in the conversation, and then saying what you want to say, that's actually fairly complicated. And for somebody with one of these diseases, they may have the thought, I want to say this, and then it goes away. And then by the time it's their turn to talk, they can't remember what they're saying or what they wanted to say. And so you notice that they're much quieter. They're not participating as much. Those are, again, potential signs. But this can be very difficult. Again, I don't want to stereotype too much, but with older men, for example, they may not have been very chatty before. They may have always been fairly quiet and stoic. And so it can be tough to use this guideline. But for somebody who has been quite chatty and conversational, this is one thing you may notice, where they're more following as opposed to taking the lead in conversation. Some of you mentioned this idea of verbal fluency. That's just a fancy term for being able to articulate yourself in a fairly rhythmic and consistent way. So it's being able to access our memory on the fly while we're talking and be able to pull those words up and then say them out loud or write them as well. So here's where you'll notice an individual maybe having a conversation and all of a sudden they lose their train of thought, or they get blocked on a word and kind of get stuck in the conversation. So it's not a smooth flowing conversation. It's more kind of choppy with lots of blocks and maybe even changes in topic. Those are things that we see earlier on in these diseases. So finding the right word, calling things by the wrong name. Sometimes people will use the wrong phrases, but what you more commonly see is down there below what are called indefinite references. That just means saying a lot of this, these, those, them, him, her. but not making a specific reference to a person, to that thing, to that event. And that's actually a wonderful compensation strategy that someone can make. And that's something that people sometimes even consciously do, is that if they can't remember the words or phrases, they just compensate by using those more vague terms, and other people may not pick up on it. But if you know them well, then that's something that's one of those little subtle things you can pick up on, perhaps. We talked about repetition already. In the earlier stages of many of these diseases, the language problems are more about production of speech, not comprehension. But the individual may have difficulty, for example, interpreting like analogies or metaphors or proverbs, those kind of more complex language. They may have a hard time making sense of those. But earlier on in these diseases, you typically see much more difficulties with the production of speech as opposed to comprehension and understanding. And then you may also see some difficulties with kind of spontaneous writing or speaking as well. And one of the difficulties there is that the frontal lobes do generally take some damage early on in the process of Alzheimer's disease and other dementias. And so when the frontal lobe becomes damaged, it's harder to initiate behavior. You can have the idea in your head, but following through with it becomes much more difficult. And this is something I'll repeat a number of times later on, is that individuals may be perceived as being lazy or not caring. And that may not be the case at all. It may be that there's some frontal lobe damage and they can't translate their thoughts into action. And so they don't do. And that may be the case with writing and speaking as well. So that's one of those reasons why we want to get this stuff checked out, because there may be a very legitimate reason why those things are happening.
I have another one, John.
Oh yeah, jump right in.
You keep using the term early signs or early. What is early? You know, I have someone in one of my discussion groups who, 2-3 years, but she's showing some of those signs, especially when you were discussing conversations and spontaneous.
Mhm.
When I ask a question, she seems to share 1, 2, or 3 of the same stories each time. Sometimes I can bring them close enough to what the question was. But so what is early on?
Typically what I'm referring to in many of these cases is before there's actually a diagnosis that's been made.
Okay.
So those things that you might see that kind of indicate or signal to you, boy, something more might be going on than just getting older.
Okay.
That's kind of what I'm referring to. But then at times I appreciate you catching that. At times I am referring to early symptoms that you would see even in somebody who's been diagnosed. But typically what I'm referring to is before a diagnosis has been made. And let me give you an example that I've spoken with. I can't tell you how many families where they eventually bring their loved one in and they're seeing some pretty significant changes in their behavior. But when you ask them, they'll say, well, geez, I've been noticing things 5 years ago. We just didn't think much of it. That's kind of what I'm driving at here, is that what are those things that people often notice before they got the diagnosis and they kind of downplayed because they thought it was just getting older or that's just his or her personality. Does that clarify things?
Yep, definitely. Thanks.
Outstanding. Yeah, not a problem at all. And it should be noted, just related to that as well, is that by the time you see any of these changes happening, there's a good chance that there's been some pathology and damage happening in the brain for 10, maybe even up to 20 years. So there's pretty good evidence that, let's say somebody starts showing symptoms in their 70s, there's probably things been going on since their 50s. Sort of the development of those plaques and tangles, which we won't get into. That's not the purpose of today's talk, but some of those biological things that happen with Alzheimer's disease, they happen very slowly and gradually, and they happen over years before the person even shows a sign or a symptom. But boy, if we can get better at noticing some of these early signs and symptoms, we might be able to get ahead of the game a little bit. And I'm going to get to that in just a minute, I promise. So some of the changes in social behavior we've already mentioned, but the thing I want to focus on more here is the very bottom point, is this idea of apathy. And that's a word that many people are familiar with, but it has a fairly specific meaning in the world of psychiatry and psychology. And this is a really important sign. And it goes back to some of that frontal lobe of the brain damage that might be happening there. But apathy is about kind of an indifference, a difficulty initiating behavior, difficulty maintaining and following through with behavior, being very emotionally unreactive. This is kind of an apathy sort of syndrome that happens. People aren't depressed necessarily. They don't experience a lot of distress about their behavior, but they appear very, again, indifferent, have a hard time kind of initiating things, and they appear very disinterested and distant. And it can be easy to attribute that to maybe depression or a psychiatric condition, or that maybe they're just being difficult and just kind of being a stick in the mud. When you see that kind of apathy, like, I just can't get him to do stuff. I tell him over and over, I just can't get, that's something I hear a lot. I can't get him to do anything. And you're noticing some of these cognitive changes, that's a concern typically. At least it's something that should get checked out. So apathy is one of those things that can be easy to attribute to, for example, retirement. Well, I just don't have as many things to do and there's no kids in the house. But busy people generally find new ways to be busy when they retire and when there's changes in life. But if you notice that lack of interest, that lack of initiation, that can mean something's going on, particularly again in those frontal lobes. That's what helps us oftentimes plan, organize, and initiate behavior. So that's a kind of an important one there. And apathy is the most common psychiatric symptom that occurs along with memory changes and dementia. So it's one of those behavioral signs to look for. Okay, so now we'll transition here. That's a whole bunch of information. We could even probably stop there, but I've got more for you, and I'll try to get through things relatively quickly. But what if you do notice that stuff? Then why get it checked out? What do we do next? And as I mentioned early on, sometimes people feel like, well, if it is Alzheimer's disease, let's just say, there's not much we can do about it anyway, so why put them through the process of a diagnosis? So I'll try to convince you otherwise if you need convincing. You might not need convincing, but somebody else you know might need convincing. And so one of the things that it may be nothing. It may just be normal aging, just stuff that happens as we get older. But there could be, and this is not often the case, but in some cases there are some treatable, reversible causes of cognitive change. Vitamin B12 deficiency, infection. I remember when I was at the VA hospital, I worked there in their neurology clinic, and we had just a few, this was a fairly rare event, but a few individuals who had such bad sleep apnea that they were getting no rest at night. And then their cognitive functioning and their memory functioning during the day was terrible. And it turns out that when you diagnose the sleep apnea, get them on the appropriate treatment, the CPAP machine, their sleep improved, and all of a sudden their memory is much better. So sometimes there are things that can be treatable that can help possibly reverse the memory loss that they're experiencing, or at least improve the functioning that the individual does have. And that's what I mean by excess disability is, even if somebody does have a form of dementia, there's things that we need to manage better in order to help that person function as optimally as they can. We need to manage that diabetes as best as we can. High blood pressure, sleep, depression. These are all things that kind of compound cognitive problems. And so if you pile this stuff up on top of a dementia, you've got somebody who's functioning even worse than they normally would be. So we need to look at those things, and that's why getting somebody checked out is important. The treatments that we do have work better in the earlier stages of the disease as well. So if we want the person to benefit from some of the medications that are out there, they're typically going to benefit more when we catch it early. This can also provide an explanation for some of that unusual behavior, because I've worked with enough families over the years to know that when some of these changes start happening, more stress and more arguments begin to happen. Why is he doing that? Why can't she remember that? These things just must not matter to him anymore. Well, that's probably not the case. It may be something more. And so when we have an explanation, even though it's a pretty awful explanation, it's not one that anybody wants to hear. at least we have a sense of, okay, this is why all this stuff is happening. And it can help us make sense of things and give us at least a strategy for dealing with it. But we can also get prepared as a family. And the individual who may be diagnosed with one of these conditions can begin to get prepared and educated to prepare for things down the road, such as when or if driving needs to be limited. Do I need to stop work or limit work? Are we eventually going to need in-home care? And the earlier you catch this stuff, the more that the person who's afflicted with this can participate in these conversations and make it very clear what they need and what they want. So I know some families will say, you're never putting me in a nursing home. And that's something that they want to know, that even if this gets worse, I don't want you to put me in a nursing home. That doesn't mean you can always follow through with that promise, but at least you know where somebody stands. Some people will say, I don't want people coming into my home to help me out. Other people will say, I'd be more than happy to have people come into my home if it helps me stay here in my home. But you need to know the wishes of somebody. And I can tell you too, is that even if you've been married to somebody for 40 or 50 years, you may not know exactly what their wishes are in terms of these things. So it really can help get them clarified. And also your adult children, if they're involved in care, really need to know these things too. So the person can make decisions about who should get what kinds of possessions. They may have some very strong opinions about who should get their favorite rifle, for example, or their favorite crock pot. Those things can be worked out now as opposed to having to guess later on. But also who might need to make decisions for me down the road in terms of finances or healthcare. And there's often difficult conversations around end of life care as well, but making wishes known. And boy, that's much easier to do in the early stages because later on the person may not be able to participate in those conversations. And so a lot of things get in the way of kind of making that next step of setting up that appointment and getting in there to get it checked out. There's a lot of practical barriers. Just finding somebody, finding a specialist can be tough. And even in a town like Mankato, that can be tough. Insurance and transportation, those are practical barriers. But then the length of the diagnostic process can be a little intimidating if you know much about it. There's might be brain scans involved. So there might be an MRI, a blood test. The psychological testing that's done that I've been involved with, it can be very taxing. Sometimes it can be 3 or 4 hours of memory and testing and language testing and problem solving testing. So these are things that can sometimes get in the way of people making that next step to set up that appointment and getting things checked out. Some other barriers, of course, is that, well, maybe it's not. Maybe I'm just making too big of a deal of this. Maybe that's just him being him or her being her. Or maybe that's just getting older. Maybe it's because of medications, some of these things. So it can be easy to downplay. If we don't think there's anything that can be done to help, we may not make that next step. But hopefully I've already convinced you that there's some reasons to get checked out medically. Many families and the individual themselves, they may not want to get checked out because they don't want to know what the answer might be. Alzheimer's disease carries a really strong stigma along with it. And people know that. People who have the disease know that very well, typically. So it can be very threatening to go to the physician to get your memory and your thinking checked out. And so you can get a lot of resistance. And that's the next thing we're going to move into here is that you may know somebody and you think they need to get checked out and you've brought it up to them and they say, no, I'm not going to do that. I don't want to go to the doctor. I don't like to go to the doctor. I don't need that. You have a problem. I don't have a problem. I've heard this stuff over and over and over again. So saying you need to get somebody to the doctor is really easy advice to give. And sometimes it's really tough advice to follow through with.
Say, Jeff,
Yeah.
I'm sorry, we've got a somewhat related question.
Yes.
I'll just read it to you. If the patient had a 4-hour test with a neuropsychiatrist with DX of white matter on brain, should the test be redone and when?
Well, yeah, the neuropsychological testing, typically that testing, it may not be redone in full, like the full 4-hour battery. In my experience, we've typically, when we do want to redo it, it's usually a year to 2 later, but a year or 18 months is pretty common. But again, different people practice in different ways, but I know that was something that if we felt like, boy, the testing was either inconclusive or Maybe it's something that can be treated in some way. We're going to do testing in it might be even 6 months, but a year is pretty typical. But that would be my best guess based on the little bit of information that I got there.
Okay, and we've gotten a couple more in, so I'm not sure if you want to answer them now or.
Go right ahead. Yeah, fire away.
All right, the first one is Alzheimer's dementia hereditary?
Mm-hmm. Okay, I'll start with that one. I'll try to
Okay.
keep it short, but there's definitely a genetic piece to this. So there's an early onset form of Alzheimer's disease that has its onset before the age of 65. That has a pretty strong genetic link. It's fairly rare. It's only about 5% or less of cases, but that has a fairly strong genetic link. The more typical, the 95% of Alzheimer's disease cases that have their onset after the age of 65, there's a genetic component to it. And without getting too long-winded, there are a number of genes that kind of increase our vulnerability or the likelihood that we have Alzheimer's disease. And the next question typically is, well, should I get a genetic test to see if I have those genes or not? And the general consensus at this point is no, because you can have, there's one that's called the APOE gene, the fourth allele or the fourth type of that gene. If you have 2 copies of that, your risk goes up, but you can still have 2 copies of that and never develop Alzheimer's disease. So you could get the genetic test, but it doesn't tell you with any degree of certainty whether you will or won't get the disease. And so it's generally not recommended because it doesn't give you a lot of specific information.
Sure.
So, but if you have a family history, particularly somebody who's a first degree relative, so somebody the more genes you share with somebody who has this disease, your risk does go up. So brother, sister, parent, for example, you're going to have a 2 to 4 times greater chance of developing this disease than somebody else. So there's clearly a genetic piece to it, but some recent stuff has come out to suggest that this is hard to quantify, but some people have quantified that up to 60% of dementia is more related to lifestyle than it is to genetics. I think there's a lot more to learn about that, but the role of lifestyle factors seems to be much greater than was once thought. But there's definitely a genetic component. I hope I've answered that question thoroughly enough. But if you have a lot of this that runs in your family, it should definitely increase the concern if you start seeing some of this stuff that we're talking about, for sure. Does that
Okay.
help? I hope.
I hope so too, yeah. And at what point should medication for memory be considered, especially if the patient is more somber than years ago and rarely smiles? And kind of a corollary to that, do studies show connection to long-term smoking and memory loss?
Smoking is definitely a risk factor for sure. So yeah, I can say that fairly conclusively. It doesn't cause it necessarily, but it's a risk factor. A lot of things that are bad for our heart are bad for our brain. So diabetes, high blood pressure, and smoking, those are big ones. Those are big risk factors. And those things in middle age, so like right in the age group that I'm in, those are big risk factors for eventually developing Alzheimer's as well. So I can give a fairly quick and conclusive answer there. And then remind me of the first part of the question, because I just had one of those moments.
Yeah, at what point should medication for memory be considered, especially if the patient is more somber than in years past?
Sure. So medication specifically for memory problems, typically what I found is that if somebody gets a diagnosis of specifically Alzheimer's disease, they'll likely be put on something called Aricept or a similar medication. And then usually another drug called Namenda as well. They'll usually be put on a combination of both of those things. Where things get more complicated is how long to keep somebody on those medications. They are useful because they tend to slow things down, the progression of the disease down. People tend to live at home longer and be able to take care of themselves longer when they take those medications. But there is a point at which the medications aren't as effective. That really wasn't the question, so I won't go into that. But typically, the medications can be quite useful if you catch this stuff early. They can be useful later on, but earlier you catch it, the more effective it can be. But it doesn't reverse things. It doesn't improve memory typically. If it does, it'd be very short term, but it slows the progression down. And I hope that helps because those are wonderful questions. So let's move on here. And yes, again, feel free to stop me with questions. If we don't get to some of the later stuff, it's not going to be the end of the world because I got through the meat and potatoes. But this is something that I really would like to spend a little bit of time with is what if it's your husband or wife and you think there's something going on and you want to get them checked out, you've made that decision and they have no interest. And I'll use some gender stereotypes is that typically the scenario is that a wife is trying to get the husband to go to the doctor. We men, we older men, we upper Midwestern men generally don't like to go to the doctor. But hopefully that's not the case with your families. But some, I think, strategies for trying to, in a sense, convince or coax that individual to get this stuff checked out is that we want to express concern and caring. It can be easy when this stuff gets very stressful to start getting frustrated and say, you're losing your mind. There's something seriously wrong. We need to get this checked out. You're going to hurt somebody on the road, for example, driving. And those are all convincing arguments, but they may not get you very far, unfortunately. So we really have to express concerns that, you know what, Mike, I've been concerned about you because you just, something's different about you. You're just not yourself, it seems to me. And then give some maybe specific examples of what those things are. That can be a much better way to open up that conversation. Not using the words dementia or Alzheimer's, but maybe thinking problems, maybe memory problems, maybe just not yourself. That can be a way to open up the conversation and have it be less threatening. Because if you've been an independent adult all of your life, you're a good thinker, smart person, and you identify yourself as a smart person, and all of a sudden somebody starts to challenge that, even just a little tiny bit, oh boy, that's very threatening to some people. So taking this approach is generally more effective, but always remember that this is general advice. You know your friend, your loved one better than I ever will. So you will probably know better the strategy to use. What I have also found is that sometimes maybe it shouldn't be the spouse that opens up this conversation. Maybe it should be somebody else. Literally last week, I was out on a walk with my daughter. She's only 17. As I said, I'm 48. But I've told her and my wife that if you ever have to have this kind of conversation with me, you're probably going to want to have my daughter do it and not my wife. I don't know why that is, but I'll do anything for my daughter. So that basically that's what I've told her. I'm like, if you ever need to get me to do something difficult when I'm older, you should ask me, probably not my wife. Again, why that is, I can't exactly tell you, but that girl could get me to do just about anything. And you probably have somebody in your family or maybe somebody outside of your family. It could be a trusted neighbor, it could be a pastor, but somebody that person really trusts and listens to. That might be a person that you want to have involved in this conversation, and it might ease into the conversation better. And if you get resistance, if you get frustration, anger, it's very important to acknowledge that. I know that this is a hard conversation. I know that you don't like hearing this. I wish I didn't have to say it. I'd be upset too. It's very important to acknowledge those feelings. So I know I'm starting to sound like a psychologist here, but those are strategies that do work very well to keep things from escalating and just getting worse. We don't want that. You want to stay on their side as much as possible. That you also can explain logic, reason. It could be something else. It could be something that's very treatable. We need to get this checked out because we might be able to identify something that we can fix. And it may be that you need to do it for your daughter, do it for your grandkids, do it for me. You know the motivations of your loved one, and those are important to kind of bring into this. And on occasion, if you got somebody who's really stubborn, it might be, well, if you don't think there's anything wrong, and I do, let's go and get it checked out, and you can prove me wrong. That's another strategy that I wouldn't generally recommend, but if you think that's going to work with your loved one, it can help get that person to make the step of getting them to the doctor. You can have the physician call you to set up an appointment for a well check, for a physical, that type of thing. Is there a question, Mike? I saw you unmute yourself.
Yeah, the question was asked, do scans always show dementia or Alzheimer's?
Your typical like MRI scan, sometimes a CAT scan is used. What they're going to show is if there's another explanation. So they're going to be able to detect, has there been a stroke? Has there been a series of small strokes? Is there some sort of a brain tumor? So that's what you're typically going to get from a scan in general clinical practice. There are scans that can be done, but they're typically only available in research settings at very large institutions where you can actually inject the person with a radioactive substance. It's not as dangerous as it sounds. And it will light up plaques or tangles even in the brain. But those are things that are not available to the general public yet because they're really expensive and it's not sure exactly how to interpret them. So the brain scans help us rule out other things. They don't necessarily show us that it's Alzheimer's disease. What you also will see sometimes on a brain scan is you'll see some general shrinking or atrophy of brain tissue, and that can give us another clue that something's happening. It may mean that there's neurons dying. So hopefully I've answered that question adequately. So these are some other strategies that you can use. You can have the physician call you to set up an appointment. It can be set up for another reason. As I said, it can just be for a general medical checkup, an annual exam, that type of thing. If you get to that point where there's an exam or there's a medical appointment set up, you can call the physician's nurse and say, you know what, we have some concerns about memory. If you could ask the physician to ask about that, to prompt it a little bit, so that you as a caregiver, that you as a person who's concerned about it don't necessarily have to bring it up, but the physician will bring it up. Because they may not always do that. If there's a lot of other medical issues to attend to, they may not ask a person about their memory or cognition. But a little prompt to the nurse can help get a bug in the ear at the physician to ask those questions. And then, you know what, sometimes a good lunch after a medical appointment can be an incentive to, okay, I'll go if we're going to go to Red Lobster. That sounds great. Not that we can do that these days, but sometimes that kind of thing can be helpful as well. And so I will spend a little bit of time because again, I don't want to keep us way over, but we do have until 3:30. Is that correct, Mike? Okay, good. So I'll get through this last little bit of information, but here I just want to emphasize that if you get to the point where you've got concerned, you convince the person to go to a medical appointment and you get to the medical appointment, how do you make the most of that time? Because that can be really tough. I can't tell you how many times I've been to the physician and in 10 minutes it's over and I'm thinking, geez, what the heck had just happened here? It goes by so fast. And my mind goes blank and I knew I had questions, but I forgot to ask them. Well, how do we keep that from happening? And when you speak with people with Alzheimer's disease and their families, these are some of the big concerns that they bring up with medical professionals. And this is not to pick on medical professionals by any means, but these are common concerns, is that the person with the memory complaint or the potential memory complaint is sometimes not spoken to directly. The physician will speak to other people around them. That's a big frustration that people have. When we know these frustrations, we can hopefully go in prepared and prevent them from happening. When people do get to the point of getting a diagnosis, they're sometimes not given a whole lot of information. They may be given a diagnosis, they may be given a prescription, and then they're sent on their way, and they don't have a lot of other information. They don't get their questions answered about what's going to happen next. What can I expect? What kind of community resources are available to me? So I've just met too many families who say something to the effect of, well, when we got the diagnosis, we were given a medication, we were sent on our way and told to come back in a year, and that was it. And people feel a little bit unsatisfied with that, and that's understandable. One piece of advice I can give you is that, and I'll get to this a little bit later at the end, is that if your physician works in a clinic that has a social worker, ask to see that social worker or get that person's information. I'm married to a social worker. I'm a big fan of them. They can get you plugged into things that physicians often don't know about because that's not their job. Social workers know a lot of stuff, and they may know a lot of things that can potentially help you out. Vine is, of course, one of those things. And so that can be a place to start, but there's a lot of other community resources as well that physicians just may not be aware of. And I'm still shocked that some physicians don't know about Vine and what Vine has to offer as well. So talk to a social worker. They're smart people. So a lot of stuff can get in the way, and I won't go into this in a lot of detail, but one of the things that gets in the way of communication between older individuals and physicians is that sometimes older individuals will defer to the expertise of the physician because of respect. This person knows what they're doing. I don't want to burden them. I don't want to bother them. I don't want to ask too many questions. I don't want to be a difficult patient. And younger people much younger than me, they have more of the attitude that they're a consumer. They don't see themselves as patients. They think of themselves as consumers. And so they kind of go into physicians' appointments feeling like, well, I have the right to ask questions. Just like if I'm buying a new iPhone, I'm going to have a ton of questions. Older people are less likely, and that's not my opinion. There's a lot of literature to support this. They see themselves as more kind of passive in the role of patient. And so they, for example, there's a lot of evidence that older individuals will, they'll underreport symptoms, or they'll kind of nod their head in agreement, or that they understand something when in fact they don't. I do this myself sometimes when I'm with the physician. And so being unprepared is something that can really get in the way. And then if you don't hear particularly well, if you don't see particularly well, if you do have some cognitive difficulties, then it's much more difficult to have that conversation and process the conversation, because our interactions with physicians are still primarily verbal in nature. They may be doing stuff to us, they may be doing tests, but there's a lot of verbal interaction there that can be hard to take in. People at best remember 50% of what a physician has said to them immediately after the appointment. So you can imagine that an hour later, a day later, you remember even less of that. But physicians and providers also have part of the responsibility here as well, is that with older patients, they tend to interact with them less. They tend to make poor eye contact. They tend to interrupt them more frequently. They tend to answer their questions less thoroughly. So that's something we need to be prepared for. They may use a lot of jargon that the average person is not going to understand. And so there can be this different way that medical providers interact with older people. And so we just need to be ready for that. I think that's becoming less common, but still there's a lot of that out there. And so we want to come, oh yeah. Did I hear somebody?
I was going to say, my mother-in-law, I took her to the doctor a few times. And after the first time, I realized that the doctor would say, "And how are we doing?" or "How are you doing?" She'd speak right directly to her. But then my mother-in-law would say, "Fine."
Mhm.
And then it would just, she'd check her heart, these things, but there was never anything about, until I wrote her a note saying, these are the things we're seeing. And then then she checked her in different ways. But that was at that age, that generation, I think they're likely to just say, "Oh, fine."
Mm-hmm. Yeah, exactly. And so that's a wonderful advocacy that you did there, is that maybe some more specific questions need to be asked as opposed to more general ones. And that's one of the reasons why I really do advocate that if memory and cognition is a concern, getting somebody else to that appointment in a lot of ways is quite essential. But we also do have to be very careful that sometimes the other person, whether it's a spouse, an adult child, sometimes that person will be given far more attention than the actual individual themselves. So we want to make sure to watch for that. But come in with a list of questions, coming in with some specific concerns that you or that they have, I think is important. So, because that's a question that's eventually going to be asked. So even if the physician asks, "How has your memory been?" and the person says, or that you say as their advocate, "Well, not so great," they're going to want specific examples. What do you mean by that? So having a few things written down, I think is really important, so that the physician can make this distinction between, is that a big deal or is it not a big deal? So having a third party there, taking some notes or asking for a written summary is, I think, also terribly important, because again, our memories just are not really good, even in the best of circumstances when we're having an interaction with physicians. And bringing a list of questions is very important as well. And in case you're not sure what to ask, well, here's the next slide. Here's a few questions that you might want to ask. And I could bombard you with a lot more of these, but it just gives you a few ideas. These are the kinds of questions that people end up asking me sometimes in support groups or in presentations that I do. And they'll tell me things like, "Well, my physician never really talked about that. They said that I had Lewy body dementia, but I don't really have a clue what that is." And so I answer those questions sometimes. But physicians, of course, can answer them as well, but that's not always something that happens. But the more informed you are, the better questions you can ask. So if you're in more of a rural community and you're seeing your general family practitioner, you may need to ask to see a neurologist. There's not enough of them in our town, but neurologists specialize in doing this. So see a neurologist if you can. Typically, physicians will make that referral to a neurologist, but you can advocate for yourself that if you're really concerned and your physician is kind of maybe downplaying the symptoms, but you still want to get them checked out, your second opinion really should come from a specialist, and the neurologist is who you'd want to see. And then you want to ask questions about the diagnosis. Why am I doing these tests? Do I really need to do these tests? Are there other reasons why I might be having these symptoms? If you get a diagnosis, what does that mean? How are things likely to progress over time? What's the ultimate kind of outcome or prognosis? What are the practical concerns with the diagnosis? Does this mean I can still drive? Does this mean I can still work? Should I still be managing my own medications? Should I have firearms in the house? These are the really practical kinds of questions that families often have, and physicians will sometimes have some guidance, but again, nurses and social workers may have much more experience answering and addressing those kinds of questions. And also sources about community care. Social workers are the people that's their job, is to know that kind of stuff. So they can get you hooked up with potentially a lot of services in the community. But as you all know, Vine is a wonderful place to start. But if somebody doesn't know about Vine, they need to get that kind of direction. So that is all I have. I talked a lot there, but I hope it was useful. I thank you all for being here and listening very patiently. I definitely thank you for your questions. And if there's more questions, fire away either in the chat or just unmute yourself and let me know what you got.
Go ahead.
Let's see. So I'm Carol and I work with Vine. I've been fortunate to work with Jeff on numerous occasions, and he's always very interesting. That was wonderful, Jeff. Something we see a lot here at Vine, you know, when I'm out doing intakes with people and doing a little assessment, one of the questions I always ask is if they have any concerns about their thinking, memory, or ability to make decisions. And I can tell that they're concerned because they don't know, gosh, these things are happening. Is this normal or is this not normal? So it's just so common, just so terribly common. And I think the tips about going to the doctor, seeing a specialist, why it's important to follow up on it is so important as well. I did want to also mention, please call Vine if you have any questions. So I appreciate Jeff relaying you on to us. We, I think, have some really good resources here in the area of dementia, caregiving, things of that nature. I'll address that in just a minute, but also the Alzheimer's Association has a wonderful website. They are a good resource. They are not just for people with Alzheimer's disease, they're for people with all different kinds of dementia. So they've got brochures and information as well. That's another really great resource. We are excited that starting in January, on the 25th of January, running through the 18th of March, we are going to be doing a virtual MindWorks program. And what that is it's basically a fitness program for the brain. And so we're going to sign people up. They're going to be on the computer, and it's really a comprehensive mental workout that should be helping them maintain or maybe improve their cognition. And it's not for people, though, with just normal aging kind of things. It's for people with some mild to moderate cognitive decline. And that will be in our newsletter when that comes out. So just be looking for that, and just give us a call if you have any questions about it, or if you know anybody who might find that really helpful. The other thing I do just want to touch on, some of our caregiver support services. I know some of you are caregivers or know caregivers. Just please let them know that we continue to do regular programming for caregivers. We do coaching for caregivers. They can contact us directly at Vine. We right now are doing virtual support groups. We were doing them in person, but right now we can't. But so anybody can join those. And we also have our respite care center here for people to actually bring in their loved one and have them be cared for a few hours every day. So just want to make sure if you have any questions about some of the services that we do have in the area, just give Vine a call and we'd be glad to talk to you about that. Jeff, I don't know if I missed anything, but you know, Jeff has been really involved with some of those programs as well. So we just really appreciate your presenting for us today and appreciate all of you for joining us. So I hope that's been helpful. Oh, the other thing I did want to mention is in the next day or two, we'll be emailing you a survey. So would really appreciate it if you would just, it helps us with our programming if you would just take the time to respond to that survey. So I'll mute myself now. Thank you again, Jeff, and for all of you for attending.
Yeah, you're very
Yeah,
welcome. And
Vine.
we're very, very fortunate to have Vine in this community because too many people with these conditions, they don't have things in the community for them to do and be involved with. So that MindWorks program is really something out there that individuals can actively do. Sorry, Mike, go ahead.
Oh, that's all right. I was just going to say that that we do have some folks on who I don't have an email address for. I have shared email addresses for those who signed up through the Vine process. But if anybody is on this call and would like to be part of that, please, if you can put your email address in either the chat and you can direct it just to me and I'll take that down. Or if you want to email me directly at Mike L, that's just MIKEL, at vinevolunteers.com. You know, as we all know, those kinds of surveys and the information we can get back from that are so important when we're moving forward and tailoring a program to fit the needs of the people. So if you could participate, that would be much appreciated. And other than that, if there were any other questions, we would certainly take those now.
Yes, and if people think of questions later on, they can certainly, they'll get to me one way or the other.
Yeah, and I do have a thank you from Mary saying you're so caring and knowledgeable, and thank you so much for helping those with memory loss and their families. So
I just saw that. I'm going to take a picture of that and make sure that everybody in my family sees that so that they know Dad does actually do something. So that's that's super sweet. Thank you.
It's okay.
I have an email address to give you.
okay,
KRISTINEPAULSON
okay,
@hotmail.com.
okay. That's from Christine.
Yes,
All right, thank you, Christine.
thank you.
All right, if there are no other questions, please, thank you, Jeff. Oh, and I did want to mention that the information about the MindWorks was in our December newsletter as well. So if you still have that one around, or if you want to access it on our website at vinevolunteers.com, you can find it there as well. I know we've got some updated information with some times and dates that'll be going in the January issue, but we do have the general information for the MindWorks in the December newsletter. Go to the About tab and it'll show you newsletter. Just go down there and you'll find it there. You can download and print it if you want to, or just take a look at the page. So thank you very much, Jeff, and thank you to everybody who showed the interest in coming to this presentation. I know I have been affected by Alzheimer's and dementia, and I'm sure that many of us out there have, and these kinds of informational sessions are so important. So thank you, everyone. If you have any questions, please feel free to contact us at Vine. We can get any information or questions to Jeff as well. So thank you, everybody. Have a great day, and then look for news coming out soon about how Vine is going to be able to reopen again after this Friday. So we're so happy to have people coming back.
Happy holidays, everyone.
Thank you. You too.
Bye now.